the thing that really strikes me from listening to the two presentations is that there's so much information out there. There's so much, the body of work that is required to get it all done is quite daunting. And I'm going to give you an idea of how we managed that in haemophilia going back to 2008, prior to the ERNs. And because it was done through the patient organizations and the clinicians, we had to do it a bit more piecemeal. And I might give some ideas as how to move it forward in a small bite-sized chunk, step by step. So I'm going to just, there we go. So this is the roadmap to bleeding disorder European care. We started way back in 1999 with initial Council of Europe or EDQM recommendations through CROIT Run. Then we was a bit of a gap up until 2008, and then we had the Haemophilia Principles of Care. And off the back of that, we had CROIT 2. Off the back of that, we had CROIT 3. Off the back of that, we had CROIT 4. And then we had new guidance based on these evidence into Principles of Care for inhibitors. Off the back of 4 and the Principles of Care and these Principles of Care, we had 5. And then we're now at the point of Principles of Care for new groups, and what we're looking at is a new CROIT 6, hopefully in the coming years. So let me just give you a bit of background of the European Haemophilia Consortium and the European Directorate for the Quality of Medicines. So the Directorate is under the Council of Europe and cannot really make binding legislation, unlike the EU. The Committee of Ministers includes foreign ministers of all of the member states, and they make recommendations to the Council. So what those draft recommendations can do is really identify the direction of where a country should go. The EDQM also maintain the European Pharmacopoeia and develop the standards and for blood and transfusion and organ and tissue transplantation and pharmaceutical care and health protection. So it's a really helpful element of the Council of Europe. The EHC has 48 European NMOs now, but when this started, we had about 35. And the difference was really, really beneficial because the Council of Europe had the 47 and we could do comparison. The EHC's mandate is really to advocate for haemophilia care within Europe under European legislation and regulations and move things forward. But a key part of moving those forward is regular surveys and data collection. As Luke's pointed out, you have to assess, change, reassess, change again. As I was saying, the official recommendations that were produced for the CROITs have been through the Council of Europe, but we've used them very significantly for the national member organizations, our patient organizations, for helping them advocate with their governments on a national level. And they provide a very significant tool for advocacy, and the power behind those recommendations coming from the Council of Health Ministers is really, really useful. So let me just kind of take you piece by piece through this in terms of evolution. So the CROIT 1, I'm not going to talk about in detail, but basically outlined that you had to identify and provide care for people with needing factor concentrates, immunoglobulins, albumin, and blood products, and really focused about self-sufficiency and minimum survival criteria, such as I'll talk about a little bit later, about 1 IU of factor 8 per capita. So 1 unit of factor 8 per person in the country. And that really was identified back in the early 90s about the minimum requirement for survival. And that initial CROIT really identified and put that initial 1 IU per capita for survival into play. But not a lot happened between 1999 and 2008 in terms of advocating on a European level. So EHAD, which is the clinician group well, prior to their development, it's now the clinician organization for bleeding disorders. But this initial meeting was with the clinicians and the patients and identified the principles of care on a national level. So every country should provide a central haemophilia organization with supporting local groups. I can give examples of that later on. National haemophilia patient registries, network of comprehensive care centres and haemophilia treatment centres, partnership in the delivery of care, safe and effective concentrates at optimum levels, home treatment and delivery and prophylaxis, and specialist services care, management for inhibitors, and constant encouragement in terms of education and resources. So these were the principles that came out, and through the patient organizations, through EHC, we sat down and we broke down these principles into key questions, asking the healthcare systems of how do you deliver, what is the level that you deliver at, and how do you match these criteria. We did that just before the 2009 process. Because we were seeing a changing evolution in evidence around learning how much you needed, not just to provide a level of care from a patient perspective on survival, but now a level of care on patient perspective of prophylaxis for children, to make sure that children did not have the same damage as the adults and were living a full and healthy life. So out of the key one out of the 2009 was that change from 1 IU per capita to 2 IU per capita. Now that was a 10-year period, so that was a long period and a small adjustment. We couldn't at the time get a recommendation on prophylaxis for adults because of the lack of evidence and the body of evidence in the science perspective, and also the lack of availability nationally. But this 2 IU gave us the capacity to treat the children and gave us the capacity to start to treat some of the adults as we move forward. But we have those 2 key recommendations of 2 IU per capita and the prophylaxis for children. 2012 rolls around and we do the survey again because the new CROIT is coming up it's a 3-year cycle. So we look at 35 countries in this case, and we look at the differences in the 19 countries that we assessed in 2009. And we had a wide range still of factor VIII consumption across the whole of Europe. So Armenia were using 0.2 and Sweden were using up on 8.56. So that pretty much, that recommendation still was there from 2009. They were ongoing. In terms of the consumption of those, 12 countries were below, 15 countries were above, and we had a reassessment on some of the other criteria on availability of treatments. So CROIT 3 came around. We got the publication out of the recommendation, and we made a very specific highlight of the process with the ETQM and their recommendations. We held a meeting at the ETQM. We launched a short video on the videos from the on these recommendations, and it really increased the visibility of haemophilia within the ETQM and gave the proposed recommendations then to the Council of Ministers. The outcome of having that prior to the 2015 and the work that we had done in the meantime, as an advocacy tool, we used the recommendations from 2012 in 2013 to get access to a national haemophilia council designated with moving things forward nationally in Romania and Bulgaria in 2016. And it continues to be used on a regular basis to advocate for more access for care to the next level. So then 2015 comes around, we have that body of evidence, we have the information in terms of the science that has been changing, and we want to advance care because guidelines should be not just about what I want to do here and now, but what I want to do next, as Luke's also pointed out. So the evidence had indicated that 3 international units should be achieved. And whilst that is really beneficial on its own, it also drags up the prophylaxis for adults criteria. And we got this ongoing requirement for prophylaxis in adults, which we didn't get in 2009, but now have it in 2015. We have the recommendation for inhibitors populations. We have a recommendation for rarer bleeding disorders. And we have a recommendation on the safety and efficacy, not solely based on cost. I'll try and come back to that one a little bit because that one's probably been more of a struggle. But I think Franz and Lutz also pointed out that recommendations need to be tangible. You need to be able to do something and measure them, and written in a way that provides that continuous assessment and is pragmatic. So the 3 IU per capita is actually very, very easy to use. The percentage of the patients on adult prophylaxis is an easy one to measure, and we saw an increase in those patient populations between 2009 and 2015. We looked at prophylactic treatment around bypassing agents and looked at that evolution over time. And we saw very, very little evidence in the evolution in 6 and 7, and said, you need to do something about this because multi-factor concentrate products are not the best source, and the guidance of where you need to be is in single coagulation factors. So as you can imagine, based on the success of all of those, we carried out the assessment in 2013 again, and published that in terms of the changes, and analysed them and wrote them up about the 2016 and where the countries are again in the initial countries. So then we move on again to the EDQM recommendations for 2016, because we've done the work again. We were seeing a formal designation process being developed for centres, and we wanted to really enhance that process as it moved forward, and development of European comprehensive care centres and European haemophilia treatment centres. And a specific guidance on those, and this is where the start of the ERNs were really starting to come about in terms of conversations. We wanted a national guidelines in terms of an aging population, which we had never seen before. We didn't have a huge amount of information in the literature, and we wanted to focus the minds of the researchers on what we need to do in the future. So we had our initial questions that I presented already, and we had an add-on question for the health of the country to see what they were doing in terms of the aging population in the build-up to the survey, and there we had that information going into these recommendations. Here we see that it increased to 4 IU per capita, so I've gone from 1 to 2 in between 1999 and 2009, and between 2009 and 2016 I've now gone to 4. So that was a massive jump, and the rationale for the 3 to 4 was the delivery of immune therapy with factor concentrate for patients with inhibitors, and providing access to that in the population. And we also got, for the first time, a minimum recommendation for the hemophilia B patients around factor 9 concentrate. So now we have a set criteria for the baseline that a European country should deliver for factor 8 and for factor 9. We also had lots of discussions in the build-up to this around the national and regional tenders, and there was previous recommendations around the recommendation for national and regional tenders. They were starting to develop, but what we were really concerned about was they were developing in the absence of the hemophilia clinicians who knew exactly how and what they wanted to purchase, and the patient organizations and the representatives. So we wanted to try and change that and get a recommendation because of the issues that we were seeing. And we want them to be formally involved, and this recommendation is a build on top of a previous recommendation to really identify that this is a key component of the delivery of care. We're also starting to see the importance of outcome data, and it not just being related to annualized bleeding rate, but also things that impact quality of life, such as time off in of education, employment, joint score, and that's more of an indicator of mobility and being able to play with your children. So linking those very specific measures with the quality of life of patients. So in relation to the first one, sorry, these are just the publication, as we did with all of them, around the CROIC 4 recommendations and the Council of Ministers resolutions associated with those advancements. So with recommendation 9, that national or regional tenders of factor concentrates, as I said, then, you know, we demonstrated in that conversation for the building up to the 2019 recommendations, pointing out that these tenders were being developed and they needed to be advanced in a way that was important. And we're starting to see more patient involvement in the purchase of newer treatments and funding models in general moving forward. And we're now starting after over the last 9 years, at this point, starting to see really national coordinated tenders of procurement to deliver care, and moving away really from smaller hospital-based products purchases where the information and the knowledge really isn't there. So we're starting to see that more and more, and even countries that have in Western Europe who are very dogmatic about switching their procurement processes have started to switch because of these recommendations. The core outcome set is defined for the development of gene therapy, but actually beneficial for many of the different types of therapies moving forward. And they identify key elements of the delivery of care and therefore the measurement of the outcomes. But as you'll see here, so the factor expression and duration of expression are very clinical in nature. Resource use is very clinical in terms of the amount that you use, but we have chronic pain and we have mental health that were put in, and they were put in specifically because the patients rated them higher than other stakeholders in the process, and therefore they were added in, and that's where we're building on for our next set in terms of outcomes for patients. As you see, we also, I mentioned inhibitors in 2 of those recommendations of the CROIC, and because of those recommendations and the advances, we started to think about the importance of inhibitor principles of care, because they need to support a smaller group within the haemophilia population in moving things forward, and to be a bit more focused on key things that were important to that stakeholder group within the population. Now, we also looked at the impact of quality of life and brought this into the 2019 guidance. And this is around BWD and another study called CVES. And what we see here is the EQ5D tool, that's a generic tool that's used in HTA. And what we really identified around these 2 separate groups of patients, so there's BWD type 1, which can have some severe bleeding cohort, and then a slightly milder cohort, or you have type 3, which is more like haemophilia, which you have a very small population of severe that bleed quite significantly, but they have access to treatment. Now, what we found was the levels of anxiety and depression across all 3 of them were more or less the same. There was very, very little difference. And when we started to look at it, the type 3s were primarily delivered, or were primarily focusing on, in the adjustment, these are slightly, so the type 3s have, let me go back and take it off. So the type 3s are primarily focused on mobility and anxiety, depression, or sorry, pain and discomfort, and that drives this anxiety depression. So have access to treatment, but bleeding quite regularly, it is problematic, and they have a treatment that delivers, but they have care, but still struggle. The type 1s are primarily driven by self-care and usual activities. So in delivering of their usual activities, they have very little access to care, and they don't have the same response. So that lack of control is driving the same level of anxiety and depression. So in delivering care, we need to think about a broader context of not just treatment, but the surrounding services associated with that. So out of that, we see additional support for patients requiring not just prophylactic treatment, but things like access to physiotherapy as well. And this is instances in terms of inhibitors of care. We also see, and I think this is probably the most interesting one, is previously we would have done IU per capita 1, 2, 3, 4, but this now sets a minimum criteria on the minimum factor level that you should achieve in anticipation for newer products and in anticipation for things like gene therapy. So it sets the baseline before we even get into that gene therapy space. We also want post-marketing data to be collected in a national patient registry and strengthening previous recommendations, as well as other recommendations coming from other areas to really advance care. We want data collection that is important to patients through CoreHeme, but we want the patients to be able to use electronic information to get that into the registries because nobody has time. And then for the sake of time, I'll just point out that currently we have the latest principles of care, which is for women and bleeding disorders, and in terms of how we manage all of those prior recommendations and make sure that they're equitable and provision of care for patients with, for women and girls with bleeding disorders moving forward, and that it's patient-centric and it evolves as we need it to evolve, as the treatment and the knowledge and the information on the research also brings us forward. And we have the physiotherapy provision, which is off the back of the inhibitors and the CROIT one beforehand. So where are we going next? EDQM is still quite focused on blood products, and a lot of the hemophilia products are moving away from that blood space. But some of the recommendations were more around collection of criteria and information and how we provide a structured care moving forwards. But we still have many other bleeding disorders that we need to have more recommendations on. We have surveys for insights into new recommendations and really addressing that health and equity that is currently there. So going back to our roadmap, it has taken us almost 20 years or just over 20 years to get it done. But the pace as you move forward gets faster and faster. And I think with the ERNs and the speed that it's coming out, breaking it down into bite-sized chunks and moving it forward to successfully advocate for new evidence is where it really needs to be. And the EDQM was instrumental for us in developing those cares, developing those guidelines, but it has been a very powerful tool and building of relationships over the last 20 years between patient groups and the healthcare professionals and governments.